সেটার আরেকটা স্টেশন থাকে, দুটো স্টেশন থাকে ইমার্জেন্সি নিয়ে, আর বাকি ক্রনিক কেস, রিসেন্ট আপডেট এবং মেডিকেল ইথিক্স এবং পাবলিক হেলথ ইস্যু, এই বিষয়গুলো নিয়ে একটা করে স্টেশন থাকে। তো আপনারা এই ফরম্যাটগুলো সম্পর্কে সবাই মোটামুটি জেনে গেছেন। তবে বিষয়গুলো মধ্যে আমার কাছে যে বিষয়টা গুরুত্বপূর্ণ মনে হয়, আমরা কি কিছু যে চেকলিস্ট আছে, কিছু কোমা, চেস্ট পেন, কমন ডিজিজ গুলোর যে চেকলিস্ট আছে, সেই চেকলিস্ট গুলো আমরা আগের সেশনে আমরা দেখেছিলাম। এই সেশনের জন্য যে কোনো বিষয় বা যে কোনো সিমটম থাকুক, সেই সিমটম অ্যানালাইসিসের জন্য একটা ফরম্যাট থাকবে, অ্যাপ্লিকেবল ফর অল কাইন্ডস অফ সিমটম। What is that format? Format for any symptom analysis. That is the details of the symptom. Any given symptom, first I have to ask about the details of the symptom. The type, the onset, the duration, the aggravating factor, the associated feature, all these things. The second important thing that we often miss, that is the etiological history. If any symptom is given, like the patient presented with jaundice and altered consciousness, then we have to ask the etiological history. What's the etiology of the jaundice? It's viral in origin or it's obstructive jaundice? Any etiological history is present or not. That is, if viral fever, the patient has any history of taking food from roadside, if the patient is coming from abroad, if the patient has any history of tooth extraction, any history of trauma, any kind of etiological history is present or not. A patient presented with respiratory distress, a patient presented with asthma, he has bronchi, prolonged expiration, it's clear that the patient is having asthma. But I didn't ask him about the etiology of asthma. If he has any pet in his room, or he has any professional exposure that can lead to asthma, all this kind of etiological history. So etiological history is also important, because if we miss any one history, then I can miss the diagnosis. For this reason, am I audible? Am I audible? Am I audible? কথা কি শোনা যাচ্ছে? কথা শোনা যাচ্ছে? শোনা যাচ্ছে। Okay. Okay. So etiological history is very much important. And next, the complication that can arise from it, like if the patient is having jaundice, the hepatic failure, ascites, if he is having this kind of complication, and the treatment complication, the patient is taking diuretics, if there is any electrolyte imbalance, renal failure, if there is any complication related to the disease or related to the treatment of the disease. So if we take this type of history, then we are going to have the perfect diagnosis, or we can reach the diagnosis easily. My next topic is acute abdomen. Some scenarios about acute abdomen. The scenarios can be common, the scenarios can be uncommon. There may be a picture or pictorial along with the scenario, and there may be no picture, pictorial, or anything else along with the scenario. So if there is a scenario about the acute presentation of recurrent severe upper abdominal pain, recurrent pain, chronic pain presented with acute abdomen, and which usually occur on empty stomach for last 2 years along with vomiting. It's a chronic recurrent pain, but occurred in acute situation. On examination, the jars are lost and there was also food drop. and the urine samples are present at different time, and study the picture and the scenario carefully and answer the questions. So there can be two parts of the question. One is the pictorial of the scenario part and the scenario part. So must be careful that if there is any pictorial along with that scenario. Next, what are the questions? It's very clear. It's an uncommon case that porphyria presented with acute abdomen, but porphyria cases presented in the Society of Medicine and other programs with porphyria is a very favorite topic, although it's not common. It's all diagnosed in Dhaka Medical College. So we must also think about the uncommon things. If there is any specific clues. So when there is a specific clue, there is color alteration of the urine and the scenario with neurological manifestation and acute abdomen and recurrent episodes. So it's clear that it's a case of acute intermittent porphyria. So mode of inheritance, the basic, parabasic sciences, these things can be asked. So what is the mode of the inheritance of the disorder? That is autosomal dominant. Parents are not suffering from such illness. How can you explain? So this is a very basic question because low penetrance. When the penetrance is low, then the parents may be or the others may not suffer from the disease. What test I want to do? I want to do urine routine examination, dipstick test for porphobilinogen and PBG. And patient develop convulsion. So if the patient develop convulsion, what can be the etiological factor? That's the serum electrolytes. We have to do the serum electrolytes. And if the patient developed convulsion, second step may be the treatment of convulsion. Can ask the treatment of convulsion or the treatment of status. Two things can combine and can be presented in the same question. So serum electrolytes, 3 drugs that should not be used for convulsion: barbiturate, carbamazepine, and phenytoin. These 3 drugs should not be used for management of convulsion. This question is taken from Society of Medicine. Jolil sir presented this question. So these types of question we can get these types of question in the IUE session. So porphyria, although it's an uncommon thing, but it's a favorite thing. So we must not forget about porphyria in case of acute abdomen. That's a common question. It's a common question and usual question that a 30-year-old man presented with severe upper abdominal pain and vomiting for 6 hours. And now the symptom is abdominal pain. What we have to see? The onset. I can ask the sir, the onset, how the pain started, what's the nature, if there is any radiation, any site, what is the site of the pain, radiation, exacerbating relieving factors, any previous history, if any associated symptom, abdominal pain, vomiting, anything else. If the patient has vomiting, what kind of vomiting is this? Onset, content, amount, type, associated feature. Etiology, I have already told the etiology of the abdominal pain. When I will say that the character type, then sir will say that it's a very severe type of pain. It's radiates to the back and it's relieved to some extent in changing posture. It's associated with fever. There may be shortness of breath or anything else. When I am saying that, sir, I want to say the characteristics of the pain radiation, then sir will give me the answer. The pain is very severe. The pain is colicky type. The pain is relieved relieved by some sort of relieving things, analgesics, and the pain radiates through the back. When the characteristics is given to me, then I can assume that what is the diagnosis and the characteristics of vomitus. Then I can say that the etiology, I want to see if there is any etiology of the severe upper abdominal pain, any history of gallstones, any drugs, any alcohol, any dyslipidemia, or is a known case of dyslipidemia or family history of dyslipidemia. Yeah. Can you see the slides clearly?
I'm clear.
Slides are, okay, okay. Next, what are the examination findings you want to look for? That's fever, tachycardia, low blood pressure, tachypnea, Cullen signs, Gray Turner signs. When the SAR answered me the characteristics of the pain, then I can assume that it's a case of acute pancreatitis. Then I can answer the next questions properly. Then I can answer the other questions perfectly. And if you don't ask the sir that, sir, I want to know the characteristics of the pain, or sir missed to answer your questions, then it's very difficult to answer the other questions. What are the other findings you want to say? Fever, dehydration, tachycardia, tachypnea, and severity signs, Cullen signs, Gray Turner signs. So when the characteristics is given, it's clear to you that it's a case of acute pancreatitis. What investigations you will do now? The investigations, very usual investigation: complete blood count, creatinine, urea, RBS, ultrasonography, amylase, lipase, plain X-ray, CT scan, calcium, SGPT, LDH, electrolytes, X-ray chest also, because it can cause ARDS. There can be a scenario along with abdominal pain that the patient is having severe respiratory distress after severe abdominal pain. ঠিক আছে? So chest X-ray is also important, and we can answer more things rather than not answering or missing any investigation. It's better to answer all the investigations that is applicable for this case. So severity assessment, the severity assessment, we all know the assessment Glasgow score and Apache score. So how can assess your severity? The question is very common, and the severity, the prognosis, prognostic factors, we have to memorize these things for IOE also, because we get this type of questions in the IOE. What is the severity index, or what may be the prognosis of myocardial infarction, and how can we assess severity? These questions can be found in the IOE, like SLE severity, rheumatoid arthritis, chronic case and acute case, severity, prognostic marker, sepsis. So these things we all should try to memorize and include these things in my IOE preparation. Next topic is seizure. The question may be different. But the answer may be same. The questions may be complicated, but the answers are same or simple. Like a 30-year-old pregnant patient presented to you with seizure for 1 hour. She had no prior history of seizure. So as there is no prior history of seizure, it's not an epilepsy. The patient is not having recurrent seizure. On examination, pulse 60 beats per minute and blood pressure is low. Blood pressure is not high. It's not a eclampsia, as the blood pressure is not high. Temperature raised and reduced GCS. So temperature is raised and GCS is reduced. So temperature is raised. It's a infective cause that can be there. Maybe encephalitis, meningitis, malaria. Anything can cause this type of, and the patient is having sepsis. The patient is having low BP, but the patient presented with seizure for 1 hour. So presented with seizure for 1 hour. This is a status. The scenario may be complicated, but the answer may be easy. So another very simple question, that a 30-year-old patient presented to you with seizure for 1 year without gain of consciousness. This question is very simple. The other question is very complicated. So we must not be alert, money. We must not concentrate in the side dish. What is the main dish? What is the problem and what we have to solve? That's the main issue. So the questions are same. What are the initial steps to be followed? So initial steps to be followed when there is seizure. We have already learned from acute medicine chapter that the assessment ABC, CABC, control of the obvious problem, airway, breathing, circulation. This is the new format for managing the critical patient. So if there is any obvious seizure, we have to manage these things first. So the current issue is seizure. It's a status. What are the initial steps? In the previous question, when I am saying the previous question or previous scenario, so this can be sepsis, this can be malaria, or this can be meningitis or encephalitis. Anything can happen as the blood pressure is low, anything. If specific question is asked about the etiology, then we can answer the question. Otherwise, the initial management steps will not differ in case of status. So what are the initial steps to be followed? Assess CABC, assess airway, breathing, circulation, maintain the airway patency, give oxygen, send blood sugar, electrolytes, calcium, magnesium, coagulation, screen and drugs level. This is given in the Davidson. So we have to follow this format. And midazolam, Bactali, nasally, lorazepam, 4 milligram. These things are not available. Diazepam 10 milligram IV. We usually give diazepam. Diazepam is available. We give it intravenously. Correct the metabolic factor. We can add another thing if the question is the previous one. We can give treatment for the etiology. If I think it's a sepsis, then I can give antibiotics. I can give fluid as the blood pressure is low. We can give the treatment according to the etiology and scenario. We can add other things along with this format. And what is the next step we want to do? Next step, I want to shift the patient to, if the seizure is not controlled, the examiner will say that the seizure is not controlled. If the seizure is not controlled, shift the patient to CCU, phenytoin 15 milligram per minute, phenobarbital 10 milligram per kg, sodium valproate 20 to 30 milligram per kg, pulse oximeter, check GCS, pulse, blood pressure, respiration, and ABG. That will carry at some point. So monitoring the আওয়াজ হচ্ছে কেন এত? So monitoring of the patient is also the part of your management step. So check GCS, blood pressure, pulse, respiration. These things will also be included in the management or your steps of management. And this is a seizure issue. We can get seizure in case of many other along with many other issues. Despite the treatment, the seizure is not controlled. What we can do, what we will do, transfer the patient to ICU for general anesthesia. What do you do when the seizure is controlled? When the seizure is controlled, I should put him in the long-term anti-epileptic drug therapy, and we'll look for the etiology of the seizure. If there is any other etiology, that point should be included if there is any other etiology of the seizure is present. If it's a case of recurrent seizure, why it's not controlled, then we should also look for that. So that step should be included in the management of the seizure. And next, going to the next scenario, some metabolic abnormalities related scenarios. Metabolic and endocrine disease is very important for problem-based question and also for IOE. There are so many problems related to metabolic and endocrine problems, metabolic emergencies, and we should be careful about these things, because we should also learn these things carefully. After giving treatment, there are many complications can arise after giving treatment of many metabolic problems. This is one scenario, that is a 60-year-old male presented with acute breathlessness. He had chronic exertional dyspnea for last 2 years. On examination, his pulse 100 beats per minute, blood pressure 70/50, respiratory rate 30 breaths per minute. ABG report showed partial pressure of oxygen 80 millimeter of water and partial pressure of carbon dioxide 70 millimeter of water. So what are the history you want to take from the patient? What are the signs you want to look for? Investigations, what may be the diagnosis, what are the treatment options, and if the patient develops same kind of condition, what can you do with this type of problems? Histories, or what are the histories we can look or we should ask in this patient, as the patient has chronic cough and recurrent chronic disease and developed a acute symptom. Chronic dyspnea developed acute symptom. We must think about the common things like the acute exacerbation of COPD, acute exacerbation of asthma, and another thing is pneumothorax, and another thing is pneumonia, superinfection, respiratory failure. And this type of patient can also have cardiac problem, can develop for pulmonary, and these patients are also prone to develop cardiac disease and can develop acute LVF as well. History should include the cough, wheeze, sputum, smoking, asthma, any treatment history, chest pain, leg edema, exertional dyspnea, any cardiac disease, fever. So that can include the factors that can lead this patient to the severe dyspnea. What are the signs? All the differentials like asthma, COPD, acute LVF, cardiac disease, these things are excluded. Treatment history, these are excluded by this history. Next, what are the signs? Then SAR can say that the patient has 20 pachyard, the patient has history of COPD, he used to take inhaler, he has chest pain or not, he has no cardiac disease, he has no exertional chest pain, he has no fever. So when I am going to tell these things, history, SAR can answer the yes, patient has cough, patient has sputum, patient has smoking 20 pack here, and the patient used to take inhalers, but the patient has no fever, no chest pain. So pneumonia excluded. The patient has no cardiac disease, and the patient has no leg edema, so-called pulmonary, and these things are excluded. So what are the signs you will look for? When history will exclude the other things, then I will say the thing that is in my mind, that is the silent chest, hyperresonant breath sound, tracheal shifting, JVP, gallop rhythm, lung-based crepitation. You can also include the lung-based crepitation. So cardiac related and respiratory complications. Breath sound, it's a very important thing, because when there is pneumothorax, there is silent chest. when I will say that, sir, I want to look for the chest breath sound, then sir will say that the chest is silent in this side or that side, trachea is shifted, and the breath sound is hyper resonant. There may be gallop rhythm, JVP not raised, there is no gallop rhythm. So after the signs are clear, then I can say that yes, the patient is having silent chest, hyperresonant breath sound. So this is a case of pneumothorax. What investigations you want to do? Extra chest, of course, the CBC, ECG, peak flow meter. Peak flow meter is a bedside test. FEV1 with peak flow meter, we can do that in the bedside. Glucose, creatinine, these things. And after that, when the findings are silent chest, hyperresonant breaths are, so my diagnosis is that this is a case of pneumothorax. What I have to do? I have to take a wide bore needle and insert in 10-second intercostal space, and ICT drain, oxygen inhalation 24 to 28%, nebulization with bronchodilators and antibiotics, glucocorticoids, and if not controlled, non-invasive and invasive ventilations. All the modalities of treatment, I can tell all the modalities of treatment, because any modalities of treatment can carry a point. If there is recurrent pneumothorax, what we can do fluorodesis. This type of question, the complication of the disease, common disease, chronic disease, having acute complication, it's a very favorite topics for our mentors. Like COPD presented with pneumothorax, the patient is having respiratory distress, develop more respiratory distress. The patient with MI, the patient has exertional dyspnea, but patient develop severe chest pain for last 1 hour. That is the patient having chronic stable angina, having unstable angina or myocardial infarction. The patient is having exertional dyspnea or exertional chest pain for last 1 year. He developed severe breathlessness. Then the diagnosis will be acute LVF. So chronic case presented with acute presentation, these things, these scenarios, step-by-step management, these things are very interesting, and these things are very twisting questions for FCBS. Going to the next scenario. Okay. If a case of hospitalized COPD patient found disoriented during the round, and he was fully oriented in the morning round, what may be the differentials? Can anyone add what may be the differentials? What may be the cause of the differentials? It's important for problem-based question and also important for long questions as well. These types of long questions already available in past questions. Anyone want to add anything?
Rupture emphysematous bulla of the background of COPD.
Pneumothorax.
Ji, pneumothorax.
Emphysematous bulla.
Ji, rupture.
Pneumothorax. Okay.
Ji.
Okay. And why the patient is disoriented? Why the patient is disoriented? Disoriented. What's the if there is pneumothorax?
This may be acute on chronic type 2 respiratory failure.
Okay, that's a good point. Because if the patient has pneumothorax, it's not necessary that the patient will get dyspneic or disoriented. Anyone want to add anything?
Type 2 respiratory failure. Acute on chronic type 2 respiratory failure.
Very good. Good point. Very good point. When the patient developed respiratory failure, and after respiratory failure, the patient get disoriented. Unless there is respiratory failure, there may be pneumothorax, there may be pneumonia, there may be LVF, there may be pulmonary, anything else, what may be the etiology. But when there is hypoxia in the brain level, then the patient will get disoriented. So there is respiratory failure. There is a compromise between oxygen supply in the tissue level and oxygen demand. So it's a respiratory failure. There may be the other causes as well. So what may be the other causes? So the common thing is that I can assume that the patient is having acute exacerbation, patient develop respiratory failure. It's a common and simple consideration. There may be pneumothorax. Pneumothorax can aggravate the respiratory failure. The immediate etiology is same, pneumothorax causing respiratory failure, or the exacerbation, there is no pneumothorax but exacerbation that is causing respiratory failure. So what are the findings we should search for this deterioration? If there is warm periphery, the findings of respiratory failures, the warm periphery, bounding pulse, wheeze, JVP, edema, intercostal chest, indrawing, clapping tremor, GCS, pupil, plantar, lungs, and the plantar as well. Because if the disorientation is more, this patient can develop the bilateral plantar extensor. So these things we will search for. So what are the findings? We will search for these things. We will search for these things. What bedside test we can do immediately? What bedside test we can do? And that can help us to find the etiology. Anyone? Okay. That's a detailed
ABG.
That's ABG. Want to do ABG? Okay. Okay. Saturation of oxygen, bedside test. That's very easy. We should look for ABG is very important. ABG is very much important, but ABG may not be available in many places. So pulse oximeter is available everywhere. We have to look for the saturation, and the saturation is 78%. And next, other investigations you want to do, then the most important investigation is ABG. ABG, you can ask ABG as well in the question to answer, but saturation oxygen, but must not miss the pulse oximeter, or this man must look for saturation of oxygen, and bedside X-ray for excluding the pneumothorax and ABG. These two things are very important at this point. And ABG report is available, and the pH is low, PCO2 is very high, and CO bicarbonate is high as well. And what is the ABG diagnosis? And ABG diagnosis, basic and paraclinical sciences. That's the point that is included in the subdomain of the ABG station. So we can also get this type of question in the IOE. And simple things, simple question, not very complicated, like OSPI. In the OSPI will get the complicated ABG question. So it's a respiratory acidosis and type 2 respiratory failure, and the respiratory failure that is the cause of the deteriorations. Additional findings, we obviously we have to look for PO2, partial pressure of oxygen. So this is a type 2 respiratory failure. You all are very much correct. So must not forget respiratory failure and management of respiratory failure in case of COPD. So principles of management, the principles of management, already we know the principles of management. We have to treat the etiology. We have to give the oxygen, non-invasive, invasive ventilation, the respiratory findings or respiratory support, but and In case of, we must be cautious in giving bicarbonate. If the pH is not much low, then we don't have to give the bicarbonate. Next scenario, and this is a FCPS question. A 55-year-old male presented with fever and unconsciousness. He is diabetic and got treatment for UTI. His condition is gradually deteriorating. Investigation showed that total count is raised, ESR raised, RBS is very high, 30 millimole, sodium 1.6, upper limit of the normal, potassium upper limit of the normal, chloride, bicarbonate okay, osmolality is very high, 330, urea 6 millimole, ketone body absent. So what is your diagnosis? From the scenario, what is your diagnosis and what is your fluid management plan, and how you are going to monitor this patient, and if the after treatment the patient, the condition of the patient is deteriorating, what can happen? So this metabolic type of questions like thyrotoxicosis, decay, Hong, and Sheehan syndrome, these types of endocrine related questions are very important, and this type of questions with the boxes, emergency boxes, are very important for emergency station preparation. This is a, as the osmolality is very high, this is a case of hyperosmolar non-ketotic coma. What fluid we should give? The intravenous 0.9% sodium chloride, 1 liter in 1 hour, and look for the dehydration mental states and the sources of the sepsis. And the patient has got UTI and the patient is diabetic, the sources of sepsis, you have to look for that. The patient, after 2 days, his condition is improving, but after the patient's condition is deteriorating. What can happen? The patient is getting treatment, is okay for 2 days, but after 2 days, the condition is deteriorating. What can happen? That is due to the overcorrection of sodium chloride, osmotic demyelination syndrome. That can happen. And for this, what are the that we expect? The findings are quadriparesis, the plantar extensor, GCS low, locked-in syndrome. The patient have quadriparesis and papilloedema. So these are the bilateral plantar extensor. So these are the findings we should look for. The patient will go into locked-in syndrome if there is any problem in the cerebellum, on the posterior fossa, large area involving the posterior circulation, then patient can develop locked-in syndrome. The patient will develop quadriparesis. But the other patient GCS deteriorate and patient will develop quadriparesis. Patient can also develop papilloedema. As large area is involved, there is cerebral edema, and patient can develop papilloedema. What complications patient may develop? Due to this type of condition, what are the complications that patient can develop? That is stroke, MI, respiratory failure, and cerebral edema. Complications and the mood of death or the mood of mortality, cause of mortality is very important. That can be asked by the examiner. So the complication that can be developed, we should think about, we should carefully handle the complications that can patient develop. And next, another scenario. These scenarios are related to metabolic and endocrine related abnormalities. This is another scenario. A 40-year-old non-diabetic male got admitted in the medicine ward with the diagnosis of pneumonic consolidation in the right side, and he is on antibiotic therapy. During the next morning follow-up, this patient is drowsy with irrelevant talk, and no focal paresis is there. Plantar bilaterally flexor, pupil normal, temperature normal, urine output normal, other vitals are normal. Uric acid, urea, creatinine, all these things are normal. So the patient is not dyspneic. There is no ischemic cause that is causing the deterioration of his GCS level. Carefully, if we carefully go through this scenario, the important points are urine output normal, no renal impairment. Pupils are normal, no cerebral edema. Plantar bilateral flexor, there is no CNS complication, but the patient is drowsy and having irrelevant talk, no focal paresis, and there is no features of sepsis as urea, uric acid, creatinine, other things are normal. So patient is having consolidation and is on antibiotic therapy. There is no feature of dyspnea, respiratory rate is increased. What may be the causes of deterioration? What may be the causes of this deterioration? Delirium is a very important point, and many things can cause delirium. So what may be the cause of deterioration in this case? Anyone want to add and want to say something about the cause of deterioration?
So it is
Hyponatremia
hyponatremia due to
SIAD.
SIADs due to pneumonic consolidation.
Hyponatremia, very good point, because there is no other things that can cause, because there is no features of respiratory failure, there is no features of sepsis, there is no features of drugs related toxicity or any drugs causing any anaphylaxis, anything. There is no such clue in this history. So what investigation you want to do in the priority basis? Obviously, you want to do electrolytes, saturation, RBS, and CT scan. But if only single investigation is asked, that is electrolytes. Serum electrolyte sodium is low. What are the subsequent investigation you want to do for this hyponatremia? So as the patient is having pneumonia, and I am assuming that this is a case of CR. So CR related investigations, I should tell about the CR related investigations like plasma osmolality, urine osmolality, urine sodium, and serum electrolytes level is already available. So sir will tell me that the plasma osmolality is 225, urine osmolality is 150, and urinary sodium is 30, more than 50, more than 30, it's more than 100. Urine osmolality more than 100, and the plasma osmolality is low, less than 230. So what is your diagnosis from that scenario? A diagnosis is shared, although other investigations, I have to do other investigations to confirm it, because I have to exclude the other things like thyroid, cortisol. If there is any clue to other endocrine disease, then I can say that I will exclude all other things like thyroid disease and adrenal disease. I should exclude other things. How to correct hyponatremia in this case? I have to correct hyponatremia with hypertonic saline, fluid restriction, oral urea, oral vasopressor, receptor antagonist, tolvaptan. So I have to correct the hyponatremia in this way. After correcting hyponatremia, in this scenario, we can get a second step of this scenario, like after the correction, the patient improved, but again the patient deteriorated, then the same condition will happen. overcorrection causing osmotic demyelinating syndrome. So any kind of hyponatremia or any kind of decay or honk related or any kind of correction related to sodium and can cause the deterioration of the problem due to treatment cause. So treatment complications must be considered if the patient deteriorates after treatment. And next, the scenario, the story is still going on. On the following day, the patient developed quadriparesis, dysarthria, diplopia, gait disturbance, and seizure. And serum sodium shows 132 millimole per liter. What happened to the patient? The clinical features or the signs, the CNS signs are given, but the patient deteriorated. And these things, you have to answer these things, that what features I have to look for: quadriparesis, dysarthria, diplopia, gait disturbance. These things I have to look for. So what happened is very clear: osmotic demyelination syndrome or central contact osmotic demyelination syndrome. It's better term because demyelination occurs in the sites other than pons also. So osmotic demyelination syndrome, that's a better term. How to establish the diagnosis? By ODS. Symmetrical hyperintensities in that areas can diagnose the ODS. Next, another issue is 70-year metabolic cause related IUE and emergencies. A 70-year-old male was a diagnosed case of lymphoma or leukemia, got second cycle of chemotherapy, developed sweating, palpitation, and seizure, and his potassium 6.5 and phosphate high, and potassium is also high. What steps you will do before starting the therapy? What are the steps you want to do before starting any therapy? So what I want to do, the common things, the assessment of the ABC pulse. When there is seizure, we have to control the seizure. That's the point. IV channel, urgent investigations, other creatinine and other investigation, blood sugar, that should be sent. Should start a IV channel, and I have to control the seizure. So seizure control, if examiner asks how you can control the seizure, then you will tell about the treatment of status epilepticus. Like I should give the diazepam, I will look for airway, I will look for magnesium electrolytes, etc., etc., etc. I will give IV diazepam, midazolam, lorazepam, this thing. So I have to control the seizure. The obvious problem is seizure, so I have to control the seizure. I should look for the assessment of airway, breathing, circulation, maintain the airway, urgent investigation, fluids, and IV channels. These are the things I have to do before starting. Next step, what you will do, I have to confirm it is as a tumor lysis syndrome. For confirmation, what I can do. For the confirmation, what I can do. What I can do, I have already sent the investigations. I have to look for the renal function, uric acid, and other electrolytes, CBCs. I have to look for other things. So for confirmation of the tumor lysis syndrome, I have to connect it with cardiac monitor, because cardiac arrhythmias, these are very common. Fluids and diuretics to excrete potassium and other things, and fluids for dehydration, allopurinol and ras-boric acid. I can hypercalcemia, I have to look for calcium level. I can tell that allopurinol and ras-boric acid in this step also, in the next step, and can also tell allopurinol and ras-boric acid in this step also. What life-threatening complications can be managed? The most life-threatening complication is hyperkalemia. The problem with tumor lysis syndrome is that the renal failure and the hyperkalemia related arrhythmia, these are dehydration. Three things are the fatal causes that lead to deterioration of the tumor lysis syndrome. So life-threatening complications, it's obvious that the patient is having hyperkalemia. Severe hyperkalemia, you have to give calcium gluconate, iron binding regime, insulin glucose drip, nebulization with salbutamol, dialysis, and if there is cardiac arrhythmia, we have to we must keep DC cardioversion ready if there is any arrhythmia. Tumor lysis syndrome is very important for our problem-based question and also important for IUE. Hypercalcemia and tumor lysis syndrome. The scenarios may be similar, but what are the other clues given? If the phosphate is also raised and the potassium and other things are raised, then it's tumor lysis syndrome. And if only the calcium is raised, it's hypercalcemia related question. Going to the next scenario. This is an endocrine related scenario. A 36-year-old man presented with agitation, restlessness, and deterioration. She is febrile and suffering from cough, sputum, and chest pain and breathlessness. From the scenario, from the initial stages, it seems that it is a case of respiratory problem, but we'll see what happens next. She is not diabetic and she is losing weight in spite of good appetite for last few months. As she is losing weight for last few months, it's a chronic case. Please go through the scenario and respond according to the examiner as the examiner proceeds. What information you want to get from the history? As the patient presented with fever, sputum, diarrhea, loose motion, palpitation, weakness, tiredness, any history of contract of TB, goiter, or any swelling in the neck. As the patient, the clue or twisting point in the question is the loosening of the weight in spite of good appetite, because the initial scenarios are indicating a respiratory cause, but when this line indicates it's not a pure respiratory case, it's a chronic case, but the presentation is acute with another complication. High-grade fever, and the sir will answer that the patient have high-grade fever, chills, purulence, sputum, loose motion, palpitation, tiredness. All these things are present in this patient. So what are the things you want to ask? What are the signs you will look for? Pulse, irregular tremor, pretibial myxedema, consolidation in the chest, neck examination, ophthalmopathy, tendon reflexes. What are the physical signs you will look? And if the pulse is irregular, tremor presence, torsis, lead lag, retraction, all these things are present, thyromegaly is present, then what are the investigations you want to do? Obviously, the thyroid function test, thyroid scan, radioiodine uptake test, thyroid antibodies, X-ray test, sputum analysis, ECG, and echo plus minus, ECG must, and CBC must, because the patient is having a febrile illness. After the investigations are available, T3, T4 raised, TSH undetectable, antibodies are positive, X-rays, consolidation, neutrophilic lymphocytosis. Now, what is the diagnosis? So, diagnosis is pneumonia with thyrotoxicosis or thyrotoxic crisis. And it's a case of thyrotoxic crisis that is precipitated by pneumonia. So the disease with complication of the disease, these things are very favorite for FCPS question. Some scenarios from the infectious disease. If the slides are visible clearly, slide গুলো দেখা যাচ্ছে?
Yes, Apo.
দেখা যাচ্ছে, ওকে ঠিক আছে। Infectious disease related question IOEs কিন্তু আসতে পারে। ইনফেকশাস ডিজিজ রিলেটেড অনেক ইনফেকশাস ডিজিজ অলরেডি আমাদের ব্যানট্রপস এর হচ্ছে বিভিন্ন ইনফেকশাস ডিজিজ রিলেটেড সেমিনার গুলো হচ্ছে, বিভিন্ন কিছু হচ্ছে। তো এই রিলেটেড আইওই বা ইমার্জেন্সি গুলো কিন্তু আমাদের জন্য খুবই জরুরি। And what are the emergencies that are related to infectious disease? A 30-year-old man, the scenario is a 30-year-old man was found unconscious in his room where he lived alone. His neighbor brought him emergency. He was febrile on admission. So when the patient is febrile on admission, immediate steps, what are the immediate steps? As usual, immediate steps, airway, breathing, circulation, bedside, sugar, pulse oximeter, channel, glucose, oxygen. And response by the examiner, the blood pressure is low, pupil normal, saturation normal, blood sugar as the lower limit, respiratory rate normal, pulse 110 beats per minute, and the patient is febrile. So what history you want to do? The fever, duration, type, associated feature, cough, chest pain, traveling in the malaria endemic zone, headache, hemiparesis, seizure, red urine, high color urine, diarrhea, any liver, kidney disease, or diabetic mellitus. Because these things, if the patient has these things, they can also lead to any sepsis. So for this reason, the checklist of coma we get that we should ask for liver, kidney, or diabetic mellitus, these types of questions. So we must ask these questions or this history, any previous history, taking history of insulin, these things must be included in the history. So sir, the examiner's response is the patient has a history of traveling in the Rangamati and the patient has diarrhea as well. What are the signs you will look for? The patient is having a traveling history of Rangamati. What are the signs you will look for? That anemia, jaundice, tender liver, splenomegaly, cranial nerve palsy, opisthotonus, road spot, pulmonary edema, bleeding, and focal sign. These are the severity signs of malaria. We should look for malaria-related severity signs. And what are the investigation? We'll do CBC with ESR, blood for malaria, parasite, thin field and thick field, rapid diagnostic test for malaria, RBS, creatinine, and liver function test. So in the peripheral blood field, only ring forms are seen. Ring forms are seen in all stages of RBS. Then what is your diagnosis? So from that scenario, my diagnosis is severe falciparum malaria, as only ring forms are seen in all forms of RBC, all stages of RBC. So this is a case of falciparum malaria. Next, another scenario, dengue and dengue related complications or dengue related emergencies are very important. COVID related emergencies are still important because COVID is now a endemic issue, and COVID related complications, doctors frequently encounter the COVID related complications, COVID related respiratory failures, and others. So we must not forget COVID and COVID related complications like COVID related ARDS and other respiratory failure and other complications. And this is another infection related scenario, infection related emergency. A 50-year-old diabetic hypertensive male presented with presented to the emergency department with dyspnea, and they gave history of fever but no cough or sore throat. Investigations showed low platelet and NS1 positive. NS1 positive, and PCV 40, pulse 80 beats per minute, normal blood pressure 120 by 90 millimeter of mercury. The day before admission, the patient was diabetic, hypertensive. The patient is on beta blocker. The patient is having diabetes, hypertension, and the patient is on beta blocker. And the patient have fever, but no cough or sore throat, low platelet, NS1 positive. It's a case of dengue, and pulse normal, pulse 80 beats per minute, blood pressure 120 by 90 millimeter of mercury the day before the admission. And next question is, the direct question is, will you consider fluid therapy for this patient? The patient is not, the patient is not dyspneic, the patient is not disoriented, but he is diabetic and hypertensive. He is having fever, low platelet, and NS1 positive. PCV is 40, not much raised. The blood pressure is 120 by 90 millimeter of mercury the day before the admission. Now the question is, will you consider the fluid therapy for this patient, intravenous or anything, or oral or extra fluid? Will you need the fluid therapy for this patient? Yes or no? So the answer will be yes, because I want to consider fluid therapy oral or intravenous. Intravenous, if patient can't take the fluid orally, then I have to give the fluid intravenously. Yes, why? Because due to narrow pulse pressure. If it's less than 40, I should consider fluid. If it's less than 20, then it's more severe. And if it's less than 40, it's in compensated shock. And if it's less than 20, more chance of decompensated, patient is in more chance of decompensated shock. So his body weight is 60 kg. Which fluid in which amount you want to give? Which fluid in which amount you want to give? So I want to the fluid management. The fluid management is a important issue, and I think we can get the fluid management issue in some form of questions, because it's a well discussed issue. So how to calculate the fluid? The weight is 60 kg. I have to calculate the first 5% deficit. How can I calculate the 5% deficit? I have to multiply the weight with 50. So weight is 60 kg and 5% deficit, for which I should multiply 60 with 50, that is 3000 ml or 3 liter. And I should follow the Holiday-Sager formula. Holiday-Sager formula, for which for 1 hour, for first 10 kg, I shall consider 4 ml. 4 ml for each kg. So 10 kg, 40 ml. 2 ml for next 10 kg. So 20 ml. 40 plus 20, 60. The patient's body weight is 60 kg. So 10, 10, 20 gone. And for the remaining 40 kg, I should consider 1 ml per kg. So for 1 ml per kg, 40 kg, 40 ml. Total 100 ml. 40 plus 20, 60 plus 40. Total 100 ml. And for 24 hours, I should multiply this 100 ml with 24. So 2400. 2 liter, 2400 ml fluid. And the deficit is 3000 ml. So total fluid deficit is 5 liter, 400 ml. How I can give that fluid? So this fluid I have to give 5 liter 400 ml fluid in 48 hours. 48 hours. In 2 days, I have to give it orally plus IV in 2 days total. And if the patient can eat, the patient can drink fluid, then I can give fluid, that the patient take oral fluid. If it's not corrected or the patient's pulse pressure is not improved, and I can give IV fluid from 1.5 ml per kg per hour for children and 40 ml per hour for adult. Next, I can switch if the mean pulse pressure is not improved. Next, I can give 3 ml per kg or 80 ml per hour for adult. And if not improved, and we will adjust the fluid and re-evaluate everything in every 2 hours and look for 6 hours. Next, despite the treatment, blood pressure dropped. As the patient is having beta blocker, his pulse rate is not increased because the patient is getting beta blocker. As the patient is hypertensive, so his blood pressure in the initial stages may not actually show the drop of the blood pressure or fluid leakage because the patient is hypertensive and the patient is on beta blocker. If any dengue scenario or any scenario is given and the associated comorbidities must be looked carefully, that can cause alteration of the natural course of the disease. Despite the treatment, the blood pressure dropped. After the treatment fluid management, his blood pressure dropped. So what can we do next? The 10 ml per kg per hour for children and 500 ml for adult. We should start fluid in this rate. But and check the ABCD and check the vitals, peripheral perfusion in every 1 to 4 hourly, and then the patient out of critical phase, urine output 4 to 6 hourly, hematocrit before and after each fluid replacement, and we should also look for blood glucose. And the patient blood pressure is still not improving and the PCV is falling. The PCV is increasing and falling. It's an important issue. The PCV is falling. As the PCV is falling, what do you want to do? As the PCV is falling, I have to give the RBC concentrate or fresh whole blood 5 to 10 ml per hour, and his blood pressure then stabilized. But the blood pressure stabilized, but the patient developed dyspnea. What can happen? What can happen after the stabilization of the blood pressure? The patient developed dyspnea. What can happen? Anyone want to add anything?
Fluid
What are the
overload.
complications after fluid therapy? What are the complications after fluid therapy? A dengue patient can develop severe respiratory distress. What are the causes?
One is
It can be a problem-based question. The dengue patient develops severe respiratory distress. What are the causes that can cause respiratory distress? Anyone?
Pulmonary edema and pleural effusion.
Dengue can cause number one, if there is severe respiratory distress, if there is dramatic deterioration in the respiration and any other clue is not given, there is no infection, pneumonia or anything is not given, dengue can cause ARDS. And sudden severe respiratory distress, and if there is no other clue is given, that is fluid replacement is not given, anything is not given, then ARDS may be the answer. And next, the over collection of the fluid. After over fluid management, the patient can develop overload. Yes. Or which the patient can develop respiratory distress. Number 3, dengue can cause renal failure. And from renal failure, and due to renal failure, patient can develop respiratory distress.
হ্যাঁ এটা কি করতে আসলো
Okay. And pulmonary edema. Pulmonary edema is another cause. Of course, pulmonary edema and dengue can cause cardiomyopathy, myocarditis, cardiac failure, for which patient can also develop respiratory distress. And what are the signs you look for? Common signs, that is, if the patient is having any cardiac complication or fluid overload. If the JVP is raised, if there is basal crepitation, pleural effusion, pleural and pericardial effusion, that can cause respiratory distress, but rarely the massive pericardial effusion, and there may be massive pleural effusion, but respiratory distress may not be severe or obvious in case of dengue related pleural effusion. So if the patient develop dyspnea, pleural effusion, pericardial effusion, that may be a cause, but they should not be in the top of the list. Basal Krebs, leg edema, and gallop rhythm. I should look for any cardiac complication, fluid overload, renal complication, pulmonary edema. So next, snake bite and poisoning. Some snake bite and poisoning related scenario, very common scenarios, and you can easily go through these scenarios. That a fisherman comes to emergency department with a history of snake bite 1 hour back during fishing in a canal with a severely bitten dead snake with him. What steps you will do before starting the therapy? The assessment and the fatal complications. If there are any fatal complications like shock, airway compromise, bleeding, limb compromise, focus investigations and evidence of envenomation. The headlines of the Davidson. I have just put the headlines of the Davidson. And what bedside test you can do? The 20 minutes whole blood clotting test. If the blood clots within 20 minutes or not. If there is coagulopathy, the blood will not clot within 20 minutes. If any features of venomous snake bite, how will give antivenom? We'll give polyvalent antivenom, and we don't have any specific antivenom. 10 ml, 10 vials in normal saline, 100 ml normal saline over 1 hour. If the patient collapsed after a few minutes of antivenom, what you are going to do? If the patient collapsed after giving antivenom, so what we should do? We should do the treatment of anaphylaxis. We will give IM adrenaline, antihistamine, IV steroids, IV fluid, oxygen therapy, nebulization, and respiratory support. Even we can have to do the mechanical ventilation. And after doing all these things, we will start the antivenom. Other features, if the patient has features of neurotoxicity, what can we give? We give atropine. According to Davidson, we can give atropine. And in the national guideline, we can give neostigmine and atropine. Atropine 15 microgram per kg, followed by 50 to 100 microgram per kg subcutaneously. The route is different every 4 hourly. This is written in the Davidson. So neurotoxic features, we can give atropine and neurotoxin. Complications of giving snake venom must be considered carefully. And another question, it's the FCPS question. In July 2021, a young male, it's a scenario of poisoning. A young male was brought to the indoor ward by emergency department by some of his relatives who ingested the large amount of pest killer for 2 hours. And his unconscious stomach wash was given in the emergency department. And how you will proceed? what are the immediate measures you will take, and how you will resuscitate him. Yeah, A, B, C, D, E, assessment, management, oxygen, IV channel, fluid. I have to look for drugs level. In case of poisoning, we must give the investigations of looking for the drug level, external decontamination. After resuscitation, how can I evaluate him? Pulse, blood pressure, GCS, pupil, axilla, secretion, any incontinence, retention, skin and any fasciculation. His pulse is 55 beats, blood pressure low, pupil consistent, excess nasopharyngeal secretion. What should we give? We give atropine and pralidoxime. With the management, the patient improved, but after 3 days, he suddenly developed respiratory distress and weakness. What are the findings we look for? We look for ptosis, diplopia, ocular muscle and cranial nerve pulses, bulbar dysphagia, dysarthria, head and neck muscles, and proximal muscle weakness, motor function, proximal muscle power. We should look for the features of intermediate syndrome. And patient has proximal muscle weakness, ophthalmophasia, diplomia, and nasal regurgitation. These things are also present in snake bite also. These are also features of snake bites, clinical features. So it's a case of intermediate syndrome. What definitive treatment you will need? You will need the mechanical ventilation in the ICU and supportive treatment. So poisoning case and treatment after, or the complications of the poisoning related scenario is there. And there is another scenario related to poisoning. The scenario is a 35-year-old male comes to emergency department with the complaints of blurring of vision with partial blindness for last 6 hours. He gives history of headaches, dizziness, vertigo for 18 hours following a recreational tour with his colleagues 1 day back. The important issue is the features are different, the blurring of vision, the visual loss. There are some other neurological features like headache, dizziness, but the clue is the recreational tour with the colleagues 1 day back, and he had no fever, neck pain, and focal signs. There's no fever, so it's not any infective cause, no clue for infection. What history you will take from this patient or his attendant? So what sign can give you the clue for diagnosis? Investigations, ABG report, results are available, then what you can do? Diagnosis confirmed. If the diagnosis is confirmed, next what you can do? So the history I should take, the history of taking alcohol, methanol spirit, amount and timing of it. Any history of cardiac disease, stroke, hypertension or diabetes, oliguria dyspnea, methanol poisoning related complications, oliguria, dyspnea, nausea, vomiting. These are the complications. And history of cardiac disease, stroke, hypertension, diabetes mellitus, the comorbidities that can, and the causes of sudden blindness, blurring of vision or blindness. These things should be assessed. What is the etiology and what may be the complication of the poisoning? These things should be addressed. I am assuming that this is a case of methanol poisoning, but what are the other differentials for sudden visual loss? And this history I should ask for this type of history, because diabetes can, stroke, this can cause sudden visual loss, headache, and these types of clinical features. What findings I should look for in the eye? This is ophthalmoscopy, papilloedema and hyperemia. This is a very important sign for methanol poisoning, papilloedema and hyperemia. Blood sugar, the investigation, blood sugar, renal function test, electrolyte, ABG, drug level. Drug level, must not forget the drug level, the ophthalmological evaluation by a ophthalmologist. And if there is high anion gap. When there is ABG report shows high anion gap, so what may be the possibilities when the anion gap is high? The patient is having visual disturbance and visual loss. Ophthalmoscopy is showing papilloedema with hyperemia. There is no focal sign. Then the diagnosis is methanol or ethylene glycol poisoning. These two things can cause high anion gap metabolic acidosis. And what you will do next, screen others for poisoning and inform the police. There is a medical issue. There may be mass methanol or ethanol glycol poisoning, because as they are in recreational too, other members can be affected by the same thing. So I should look for, as a medical issue, I should look for if others are having this sort of problems, or screen for poisoning and inform the police that the patient taken this thing and he developed this type of problem. So this is, police should look into this matter. If there is any medical issue related to the question poisoning, it's a medical issue. If the patient died, what you should do? We should inform the police, and the police will do the post-mortem. Next, the police will hand over the dead body. So medical issue, what you will do next? The medical issues must not be forgotten in case of poisoning. All kinds of poisoning or any unusual death or poisoning, we must not forget the medical issues. Questions related to abortions. Okay, the name the 4 drugs that can be used for the management of this his complaints. That is fomepizole and ethanol, and other drugs. I can use the sodium bicarbonate. If the patient ABG report is not available, but the patient is hyperventilated, I can use sodium bicarbonate. We can do dialysis. Dialysis can do a better prognosis for this patient. And 2 drugs that can be used as a supportive, that is IV glucose and IV niacin. We can give IV glucose, niacin, sodium bicarbonate, injection fomepizole and ethanol. These are the definitive treatment for this patient. If the visual loss is temporary or permanent, the visual loss can be permanent. If the poisoning is severe, it's not reversible. Next, another questions related to poisoning. A 60-year-old male was found unconscious in the road. Policeman brought him to the emergency department. There is no accompanying person with him. I have shown such type of question. The questions are similar, but the evaluation and findings are different. This type of question I have in the previous session, I have shown one kind of this type of question, and the diagnosis was locked-in syndrome. But in this case, the diagnosis is different. It's related to poisoning. Immediate steps are common: airway, breathing, circulation, bedside, sugar. The checklist for coma is common: pulse oximeter, IV channel, glucose, oxygen inhalation, pulse, tachycardia, blood pressure raised, pupil dilated, saturation normal, respiratory rate 14, blood sugar normal. What are the other signs I have to look for? Any focal sign, neck rigidity, signs of trauma, smell of breath, any poisoning, and any needle mark, cranial nerve palsy, any fever. I have to look for the checklist of coma. It's given in the previous slides. In the previous sessions, I have shown the checklist of coma. What are the investigation you will do? I'll do the CT scan, creatinine, ABG, liver function test, and drug screen. CT scan was normal. CT scan was normal and the other functions are normal. So what is your diagnosis? So next, my diagnosis is roadside poisoning, that is benzodiazepam, because the pupils are dilated. Pupil, in case of poisoning, pupils are very important. We have to look for pupil every time when there is a case of poisoning is given. Pupil is a very determining factor. When other things are excluded, this is a roadside poisoning or benzodiazepine poisoning because other things are clear. There is no focal signs or anything else. Everything is normal. Next issue, hypertension or hypertension related complication is a very important issue. It's a very important for recent update and also important for emergency issue. There are many hypertension related emergencies, pregnancy related hypertension, hypertension related other issues are there. And this is a case of a 60-year-old man presented with severe shortness of breath. On examination, blood pressure is 180 by 120 millimeter mercury, lungs bilateral crepitations, ophthalmoscopy revealed papillary edema. Blood pressure is high, lungs bilateral crepitation, and often and the presentation is shortness of breath. When the blood pressure is high, patient presented with shortness of breath, we must think for hypertension related complications. The target organ damage related to hypertension. The target organs are the heart, the kidneys, and the eyes related complications, hypertensive retinopathy, retinal related complications. So in the lungs or in the heart, there is shortness of breath, bilateral crepitation. So the patient is having acute LVF, ophthalmoscopy revealed papillary edema. So hypertensive retinopathy. When there is papillary edema, there is hypertensive retinopathy. Target organ damage is there and hypertension is there. It's a case of hypertensive emergency. If the end organ damage is not there, that can be a hypertensive urgency. What are the histories you want to take? Duration, type, aggravating relative factor, history of any MI, diabetes, cardiovascular disease, any hypothyroidism, CKD, any other endocrine disease, renal disease that is causing the severe hypertension, renal artery stenosis, any etiological factors that can cause hypertension. I have to look for these things, the details of the dyspnea, the details of the presenting symptom, any etiological factors that can cause the hypertension, and the complications related to the hypertension. It's already given that patient is having dyspnea. What are the signs I have to look for? There may be general examination signs, there may be cardiac related signs, there may be renal system related signs. So we can divide the signs in system wise and learn the signs as a system wise manner so that we can easily answer the question in the IUE or OSCE. Xanthelasma, puffy face, renal bruit, thyromegaly, tendon xanthoma, Cushing syndrome, that related to etiology, and other signs are given. We can look for the focal signs. It can cause intracerebral hemorrhage and can cause focal sign. There may be cranial nerve pulses related to focal sign. So these are the signs in the general examination. Actually, the cardiac related signs are gallop rhythm, bilateral tachycardia, bilateral lung-based crepitations, and ophthalmological signs. There may be other hypertensive hypertensive retinopathic signs. So we have to learn all the signs of hypertension carefully. What management you want to give for this dyspnea? Dyspnea is due to acute LVF or pulmonary edema. I want to give him the treatment of pulmonary edema. The moral of the story is I am looking for pulmonary edema treatment. So sit the patient up, high flow oxygen, Lasix 50 to 100 milligram, CPAP, GTN 20 to 200 microgram per minute, and other things. Labetalol, it's not in the box. Injection labetalol and sodium nitroprusside. And the patient is having hypertensive emergency and acute LVF, I have to lower down the blood pressure in the 25% in 1 hour with injectable Injectable antihypertensive, labetalol or sodium nitroprusside. GTN will also lower down the blood pressure. If it's lowered the blood pressure in the right way, then we don't have to add other things. So I have to tell these things first. And after the treatment, what complication can arise after the treatment? Although the treatment is given, the patient can develop renal failure or the patient can develop visual loss. That can be given in the next stage or next series. So all the complications are treatment related complications. The patient can, the blood pressure can be very low. The patient can develop shock because GTN can lower the blood pressure very quickly. The patient can develop MI and the blood pressure can lower down very rapidly. So if the blood pressure gets down very quickly, what we can think, what can happen if the blood pressure goes down very rapidly, that can be the complication of the antihypertensives like GTN, labetalol or antihypertensive drugs. So we should review the antihypertensive drugs and we should reduce the dose or stop the IV infusions when it's going down. And we should look for other cardiac complications if there is any other cardiac complication. It's like if the patient developed myocardial infarction, chest pain, or anything else like this. So any complications or further complication, further steps must be considered in case of IV preparation. Okay. Young patient, it's another scenario of near drowning. The patient developed respiratory distress and toddy secretions after near drowning. After near drowning, the patient developed toddy secretions and respiratory distress. Respiratory distress. Immediate steps, what we should do, the immediate clinical information, the submersion, duration, where, GCS, vitals, cyanosis, the ABC, and the vitals are abnormal, saturation low. What we should do, clear the airway, give the basic life support, and CPR, respiratory support with face mask or even intubation, correct the hypoxia, hypothermia, hypoglycemia, and metabolic factor. Maintain the circulation with intravenous fluid. So this is the management plan for near drowning. So respiratory support, the specification of the respiratory support can be given. If the saturation is low, very low, we have to give the BiPAP, CPAP, or invasive, non-invasive, then invasive ventilation. If the patient is in arrest, then we straightly go to the mechanical ventilation. And when there is no signs of life, that is no respiration or no pulse, then we have to give the basic life support, CPR, first. So the steps of basic life support and advanced life support is should be discussed first, then we will give the respiratory support or anything else. If the respiration is not there, then there is no need to give any respiratory support. If after basic life support the respiration again respiration reappears, then we can give the respiratory support. Patient is dead within 30 minutes. What is the cause of death? The cause of death is important: respiratory failure, ARDS, and cerebral hypoxic injury. These two things are the cause of death in case of near drowning. And another important issue is bleeding. Very much important issue, bleeding. It's a little bit complicated, but we all should try to consider every word of this scenario. It's a young male, 35-year-old male, presented to emergency department with the complaints of par-oral and par-rectal bleeding, and he has no bleeding from other body side. He had a history of jaundice 3 years back. What are the initial steps we should do, and what what are your considerations or differentials regarding this scenario? I hope anyone will join and discuss something and what may be the considerations regarding this scenario. Anyone can join. Please, anyone can join.
Rupture hematomesis due to portal hypertension, due to CLD,
Okay,
due to which
okay, very good, very good.
this one may be a probability for chronic hepatitis.
It's not clear. The second line is not clear. Can you hear me? The second line is not clear. The scenario is interested, but the common scenario, we commonly find the patient presented in the emergency department with hematemesis and melena and parrectal bleeding. Parrectal bleeding is not actually melena. It's parrectal bleeding, means it's fresh bleeding, and he has no bleeding from other side. There is no other side like ecchymosis, petechiae, any other side bleeding. He has a history of jaundice. So my first consideration is it's a case of variceal bleeding. So, but why parrectal bleeding? Why there is parrectal bleeding? It's a concern
When
from this scenario.
large
Why
amount of
there is
bleeding may
parrectal
can
bleeding?
parietal whisper.
Sorry.
When bleeding from esophageal varices, a large amount, it may happen and fresh blood may come out from parietal.
Fresh blood may come out. Okay. Okay, let's see what happens.
Usually we expect
Okay,
an
what are the
altered
initial
blood.
steps? Are rectal bleeding? That means the bleeding is coming from the rectum. From rectum, parrectal bleeding from the not from the upper GI tract. It's coming from the lower GI tract. Okay, we should, as we'll proceed, we can get the answer. So what are the initial steps you want to take? That is CABC. Obvious problem is bleeding. So airway, we have to maintain the airway patency, breathing, the circulation, and intravenous fluid line, oxygen, blood grouping, CBC, urea, creatinine, liver function test. We have to send all these things for proper management of the patient. Next, his bleeding is not controlled and blood pressure is low. What next step you want to take? So I have to shift the patient. I can't manage the patient in the emergency department. I have to shift the patient to the specialized care unit or hepatology unit. I can say the specialized care unit because there may not be HDOs or there may not be ICUs. If there is any specification that the patient is in this hospital, then I can say that the patient is in BSMMU. Then I can say that I can send the patient to the HDO. But the patient is in Shodor Hospital of that district, then I can't say that I can send the patient to any HDO. But I can say that in non-specific, shift to specialized care unit, give injection. I am assuming that it's a variceal bleeding. I can give injection terlipressin, endoscopy of the upper GI tract. Difference between upper GI bleeding and variceal bleeding is that in case of non-variceal bleeding, we use crystalloid, but in case of variceal bleeding, we use colloid, fluid colloid. And in case of non-variceal bleeding, we do endoscopy after stabilization of the patient. But in case of variceal bleeding, we do immediate endoscopy, urgent or immediate endoscopy. We give fluid portion is missing, we will give fluid, IV intravenous fluid, that is colloid. And endoscopy of the upper GI tract will give phosphate enema, antibiotics, injection, PPI. We will give all these things are given written in the box, emergency box. Which antibiotics we will give and why we will give. I will give broad spectrum antibiotic, cephalosporin, piperacillin, or tazobactam. It's written in the Davidson management plan. So I have written it because sepsis is common and survival is more with survival benefit is there if we give antibiotics. So when there is survival benefit and sepsis is common after variceal bleeding, so we should give the broad spectrum antibiotic. Endoscopy, will do the immediate or urgent endoscopy. Endoscopy reveals first degree varices with no bleeding from that side. What you will do now? The total endoscopic finding is not given, but it's not a variceal bleeding. As far the endoscopy report is available, it's not a variceal bleeding because varix is only first degree varix, so it's not bleeding. If we go through the management option of the variceal bleeding, from there we came to know that the patient with cirrhosis, 20% bleeding is from non-variceal source because there are other causes, low platelet and peptic ulcer disease, and other causes also cause hematemesis in case of cirrhotic patient. In case of cirrhotic patient, 80% cause of the bleeding is due to esophageal varices, but 20% cause is due to non-variceal causes, due to peptic ulcer disease and other causes that may be due to low platelet and other causes that increase the peptic ulcers in case of cirrhotic patient. So liver function is altered. What may be the cause of rectal bleeding? When the rectal bleeding is there, what may be the cause? So there may be low platelet count, for which there may be from the low trauma, its bleeding is there, and rectal hemorrhoid or rectal varices. Not hemorrhoid, rectal varices. There is also hemorrhoids due to cirrhosis, hemorrhoids, not hemorrhoids. Due to cirrhosis, the varices can occur in the rectal area. So that can rupture and that cause parectal bleeding. And I have seen many patients with rectal bleeding due to cirrhosis of liver. So cirrhosis causes rectal varices as well as esophageal varices, for which patient can have parectal bleeding. Not due to esophageal varices, what can I do? Endoscopy revealed that it's not due to esophageal varices. What I can do, then I can stop the terlipressin, and the treatment I should do the treatment according to the non-variceal bleeding. Then I can switch to the crystalloid solution. Next, I can do the when the bleeding site is in the gastric or duodenal area. I can coagulate it with heater-proof and other things. And should we correct the anemia in case of variceal bleeding or in case of rectal bleeding? 7 and above. 7, if it's below 7, we should give the blood, and there is no additional benefit if we give blood if it's above 7. So 7 is the cutoff point given in the Davidson when we can give blood. Otherwise, we should correct the volume with the fluids. So this is the end of the scenarios. Thank you all. The preparation never ends and the question never ends. We all have to go on and on with all our preparations, and hope you all are preparing well from the beginning of the sessions regarding IOE. It can carry very good marks and you can get very good results from the IOE with the little preparation. And if there is anything you want to add in these sessions, I have tried to include all kinds of scenarios related to symptoms, but headache, one symptom that scenario is missing from these sessions. But I will include this type of the missing sessions. You will get the questions from the exams, because in the coming sessions you will get the IOE related emergency question. There you can get the other missing symptoms of IOE points. Anybody wants to add anything? Thank you for your patience hearing. Anyone?
ম্যাডাম একটা কোশ্চেন ছিল, জাস্ট টপিক্সের না, কিন্তু এটা কোশ্চেনের অ্যান্সারটা খুঁজে পাচ্ছি না আমি। মানে মেকানিজম অফ ফ্লুইড লিকেজ ইন ডেঙ্গি, এটা জয়িসা সেদিন ক্লাস নিয়েছিলেন, ক্লাসটা করতে পারিনি, কোশ্চেনটা দেখলাম।
Okay, it's a very important issue. এটা খুবই জরুরি বিষয়, এবং এটা হচ্ছে যে মানে এটার একটা আলোচিত বিষয়, এবং এটা আমরা একটা এসিকিউ আমাদের একটা সেশন হয়েছিল, তাহমিনা ম্যাডাম সহ ছিলেন, স্যাররা ওয়াদুদ স্যাররা ছিলেন, আমাদের এসিকিউ কোশ্চেন কিভাবে করতে হয় সেটার একটা সেশন ছিল। প্যাথোফিজিওলজি সবকিছু জানা খুবই জরুরি। ডেঙ্গুর কারণে, ডেঙ্গুর যে কারণে হয়, ডেঙ্গু ভাইরাসের কারণে, সেটা যখন হচ্ছে এন্ডোথেলিয়ামে যায়, এন্ডোথেলিয়ামের সেখানে সে হচ্ছে অনেকগুলো সাইটোকাইন্স যেগুলো রিলিজ করে, এবং সাইটোকাইন্স গুলো হচ্ছে, এটার মধ্যে হচ্ছে দুইটা কথা আছে, একটা হচ্ছে দুইটা মানে থিওরি আছে, একটা হচ্ছে এগুলো ম্যাক্সিমামই যেটা যাচ্ছে ইমিউনোলজিক্যাল কজের কারণে। আসলে ইমিউনোলজিক্যাল ডেঙ্গু ভাইরাসের এগেনস্টে আমাদের বডির যেগুলো ইমিউনোলজিক্যাল কজে যেগুলো সাইটোকাইন্স রিলিজ করতেছে, সেই সাইটোকাইন্স গুলো এটা ইনফেক্টিভ কজ না যে গিয়ে ডেঙ্গু ভাইরাস গিয়ে এন্ডোথেলিয়ামকে ড্যামেজ করে ফেলতেছে, সেই এন্ডোথেলিয়ামকে দিয়ে গুতাগুতি করতেছে, এরকম কিছু করতেছে, এরকম কোনো ব্যাপার না। যেমন ম্যালেরিয়া গিয়ে আরবিসি তে গেল, আরবিসি তে গিয়ে আরবিসি তে প্রলিফারেট করলো, করে আরবিসি কে ডিস্ট্রয় করে দিল, আরবিসি ডিস্ট্রয় করে দিল, আরবিসি ভেঙে দিল। এটার পুরোটাই হচ্ছে ম্যাক্সিমামই হচ্ছে যেটার থিওরি, সেটা হচ্ছে ইমিউনোলজিক্যাল ডেঙ্গু ভাইরাস ওখানে প্রেজেন্সে থাকার পরে সেখান থেকে আমাদের যে ইমিউনোলজিক সাইটোকাইন্স রিলিজ হয়, এবং সাইটোকাইন্স গুলো রিলিজ হয়ে সেগুলো হচ্ছে ক্যাপিলারি যেগুলো ওয়াল আছে সেখানে ইডিমা করে, সেখানে ওয়াল গুলোকে মাঝখানের যে স্পেস গুলো থাকে সেগুলোকে বাড়ায় দেয়, সেখান থেকে ফ্লুইড লিকেজ হয়। আর নিউরোলজিক্যাল যে ম্যানিফেস্টেশন হয় সেগুলো বলে যে ডেঙ্গু ভাইরাসের কিছু নিউরোট্রপিক হচ্ছে অ্যাট্রাকশন আছে, সে নার্ভে সরাসরি গিয়ে বসে সে নার্ভের কিছু নিউরোট্রপিক কিছু অ্যাকশন করতে পারে, জিবিএস এইরকম টাইপের কিছু করতে পারে। কিন্তু ম্যাক্সিমামই যেগুলো আছে ইমিউনোলজিক্যাল স্পেসিফিক মানে কি কি সাইটোকাইন্স রিলিজ হয় সেগুলোও দেওয়া আছে। আমি এগুলো অ্যাড করে দেবো, আমার স্পেসিফিকলি এখন মনে নাই, আমি অ্যাড করে দিব। মেইনলি যেটা এটা একটা ইমিউনোলজিক্যাল, এটা হচ্ছে প্রথম কথা, মানে যা কিছুই হচ্ছে লিকেজ এগুলো পুরোটাই ইমিউনোলজিক্যাল, নট একদম সরাসরি ইনফেকশন রিলেটেড কজ। আমি এটা অ্যাড করে দিব গ্রুপে বা হোয়াটসঅ্যাপ গ্রুপ যেটা আছে সেখানে অ্যাড করে দিব। এটা কিন্তু আসতে পারে, এটা আইওই তে ডেঙ্গু রিলেটেড ইমার্জেন্সি কিন্তু আসতেই পারে। ডেঙ্গু রিলেটেড সিভিয়ার ডেঙ্গু কিভাবে ম্যানেজ করব, কি হলো না হলো, কমপ্লিকেশন হলো, খুব ভালো একটা কোশ্চেন, এবং আমার মনে হয় এই নেক্সট আইওই তে আসার জন্য খুব ভালো একটা কোশ্চেন কিন্তু ডেঙ্গু ম্যালেরিয়া এই বিষয়গুলো। নেক্সট কিছু অ্যাড করতে চান?
আরেকটা
Next
ডেঙ্গু
one.
রিলেটেডই ম্যাডাম, মানে এটাও আমি বুঝতে পারছি না, মানে হোয়াই হাইপোক্যালসেমিয়া কেন হচ্ছে ডেঙ্গুতে, যে আমরা এবিসিডি
Hypocalcemia?
দেখি, অ্যাসিডোসিস, তারপর হাইপোক্যালসেমিয়া।
হ্যাঁ, আমরা ডেঙ্গুতে এবিসি দেখি, ক্যালসিয়াম লেভেল কমে যাচ্ছে কেন, হাইপোক্যালসিমিয়া কেন হচ্ছে? হাইপোক্যালসিমিয়া কেন হচ্ছে এটার কারণ আসলে আমিও জানি না। হাইপোক্যালসিমিয়া, ক্যালসিয়াম লেভেলটা কেন কমে যাচ্ছে এটার কারণ আসলে আমি খুঁজে পাইনি, খুঁজে দেখতে হবে, খুঁজে দেখতে হবে। এটা একটা ভালো পয়েন্ট। ক্যালসিয়াম লেভেল আমরা দেখি কিন্তু হাইপোক্যালসিয়াম না। ডেঙ্গু রিলেটেড অনেকগুলো আসলে হাইপোথিসিস আছে, মানে সে যে কিভাবে করলো লিকেজটা, এগুলোর মেকানিজম আসলে খুব ভালোভাবে এখনো ক্লিয়ারফুলি যে বলতে পারছে যে কার্ডিয়াক কজ, নিউরোলজিক্যাল কজ কিভাবে করছে। হাইপোক্যালসিমিয়াটা দেখতে হবে, হাইপোক্যালসিমিয়াটা আমি জানি না আসলে, আমি খুঁজে দেখতে হবে, দেখতে হবে, খুঁজে দেখলে অবশ্যই কোনো না কোনো হাইপোথিসিস বের হয়ে আসবে। এগুলো দরকার আসলে, এগুলো আসলে যে কোনো কোশ্চেনের সাথে কিন্তু অ্যাড করে দিতে পারে। প্যাথোফিজিওলজি কিন্তু এখন প্রবলেম বেসড কোশ্চেনেও অনেক জানতে চায়।
প্যাথোলজিস্ট জিজ্ঞাসা করেছেন ম্যাডাম, তো আমি অ্যান্সার দিতে পারিনি। আর আগের কোশ্চেনটা জহির স্যারের একটা কোশ্চেন, আমাদের প্রফেসর জহির স্যার যে কোশ্চেনটা নিয়েছিলেন, কিন্তু আমি
জহির
ক্লাসটা
স্যার।
করতে পারিনি। এই জন্য আমি আর কি, আমি কোশ্চেনটা দেখে পরে আনসার খুঁজতেছিলাম, কিন্তু আমি পাচ্ছি না আর কি।
ওকে ওকে, আচ্ছা আমি দেখবো।
থ্যাংক ইউ
আমি
ম্যাডাম।
আসলে এটা তো দেখা উচিত ছিল, আমি দেখার চেষ্টা করব, নিশ্চয়ই আমরা সবাই দেখার চেষ্টা করব। মানে গুরুত্বপূর্ণ দুটা কোশ্চেন কিন্তু, কারণ প্যাথোফিজিওলজি গুলো জানা কিন্তু খুব দরকার। এটা প্রবলেম বেসড কোশ্চেন আসতে পারে, কেন প্লাজমা লিকেজ হয়, এটা ওই এসিকিউ তেই কোশ্চেন ছিল কিন্তু আমাদের, যেগুলো কিভাবে হাউ টু কনস্ট্রাক্ট এসিকিউ কোশ্চেন, সেখানের মধ্যে কিন্তু এই কোশ্চেনটা ছিল যে মানে ডেঙ্গুতে লিকেজের কারণটা কি, একদম সেই রকম সেম কোশ্চেন ছিল। তো এই কোশ্চেনটা যে কোনো একটা সময় পেয়ে যাওয়ার সম্ভাবনা কিন্তু খুব বেশি। জি, আর কিছু অ্যাড করতে চান কেউ? অ্যাড করতে চান কেউ আর কিছু? থ্যাংক ইউ। আপনারা হচ্ছে কোনো কিছু অ্যাড করতে চান বা কিছু, আমরা গ্রুপেও মানে ইলিয়াস ভাই তো হচ্ছে খুবই অ্যাক্টিভ, উনি সবসময় সবাইকে সচল রাখছেন, এবং গ্রুপে কোনো কিছু থাকলে স্পেসিফিক বিষয় আমরা ডিসকাস করতে পারি, হোয়াটসঅ্যাপ বা যে কোনো গ্রুপেই হোক। এই বিষয়গুলো আমি চেষ্টা করব বের করে পুরোপুরি ক্লারিফাই করে দেওয়ার জন্য, চেষ্টা করব বের করে, কোনো না কোনো জায়গায় নিশ্চয়ই আছে। ধন্যবাদ সকলকে। রহিম ভাই বা ইয়ে ভাই কি আছেন? তাহলে আমরা শেষ করছি, আমি স্ক্রিন শেয়ারটা বন্ধ করছি। নেক্সট ক্লাসে হয়তো আইওই এর যেগুলো কোশ্চেন সেগুলো থাকবে, সেটা হয়তো অফলাইনে একসাথেও নিতে পারে, কারণ এই এর পরের ক্লাসগুলো তো অফলাইনেই হবে আসলে। আপনাদের সকলকে ধন্যবাদ, আমি এখানেই শেষ করছি। রহিম ভাই বা ইয়ে ভাই আছেন ডিসিএ থেকে? আমি লাইভটা শেষ করছি, হ্যাঁ লাইভটা। ধন্যবাদ সকলকে। স্ক্রিন শেয়ারটা বন্ধ করছি আমি।